Or I'm not. Okay. Well, I don't even see a record button and I'm the host. What is this?
I see a record button.
Yeah, I
If
see
you
a
see a record button.
button.
How? What the heck?
Should I hit it?
Oh, it's spitting back to me. Oh boy. What is happening?
I think I'm gonna.
Oh, it's because I'm on the channel. There. That was fun. Okay, you guys still there?
Yep.
All right, some technical difficulties. All right, record. There we go. Okay. Welcome, everyone. My name is Brian Martinez, and I'm the director of MySec Lansing. Thank you for joining us. This is the first ever completely virtual MySec meetup, as far as I know, at least for the Lansing area. I want to remind everyone right at the top of this that the session is being recorded and hopefully successfully being live streamed out to our YouTube channel right now. I know there's some new folks here who have tuned in tonight for the first time. So first of all, thank you for attending. Getting this thing up and running has been fairly nerve-wracking, but here we are. Hopefully everything is working for everybody. I'd also like to give you a rundown of who we are and what we are as quickly as I can here. MySec is a statewide information security community. We have 6 chapters now: Lansing, Detroit, Southfield, Jackson, Grand Rapids, and new this month, we have Ann Arbor, which I'm pretty excited about. All of our chapters have an educational meetup, such as this one, the second week of every month. Lansing's is always the second Wednesday of every month. When we're not sheltered in place, we have a social outing the final week of every month. Some of our chapter directors have already done a virtual hangout with great success, so that's pretty cool. I didn't do one last month just because I was busy, quite honestly. We are an open community. There are no barriers to entry. The only requirement is you have a curiosity to learn more. Our membership is comprised of people who don't even work in security, let alone IT, all the way through seasoned professionals in the InfoSec industry. Our goal is to build each other up and continually help support the community who got us to where we are today, whether it's providing a shoulder to lean on, an ear for listening, or helping make important connections for you with people to help you land a job. You can find out a touch more about our directors and our events at our website, mysec.us. You can also find us on Twitter under the username MySec, of course, MISEC, or by looking for and following the hashtag MySec. We also have a very active Slack community with just over 700 people participating and around 150 daily active users spread out over a few dozen channels of various interests, not just InfoSec. We've got channels on blogging, sports, what else? Data science. We got a number of channels that you can join up and talk to people about those types of things. We have a newsletter that we publish monthly, which unfortunately I'm behind on this month. I'm the one that does a lot of the work on that. But in the newsletter, we promote any and all things InfoSec around Michigan that we can easily find or that people have shared with us. If you'd like to join up on our Slack or get on our newsletter, just shoot me a message through whatever medium you're on right now and watching, whether it's YouTube or shoot me a message on Zoom or just reach out to me on Facebook or Twitter. With all that said, I'm quite pleased to have Lieutenant Dave Osland and Daniel Vosell here with me this evening to talk about emergency management, risk management, and COVID-19. I'll let them introduce themselves because they can certainly do a better job than I. But before I do that, one last reminder here. This panel discussion is being recorded, and I would ask that you keep yourselves on mute until we get to an open Q&A section, if we get to an open Q&A section. I asked questions ahead of time of a number of people, and those are the questions we're going to go through one at a time. I'll share the link in Zoom and YouTube. I think I already shared it in Zoom, actually, but I'll make sure to get the link over to YouTube as well. You're free to chat in the chat window, but do know that everything you say in there is also recorded. I understand that things could become politically heated, and I will make every effort I can to avoid that. I also understand it might be even necessary to name names such as President Trump or Governor Whitmer, but I respectfully ask that we keep it civil and objective. Thank you for listening to all that. Now I will hand the introductions over to our panelists, starting with Lieutenant Osland. Lieutenant?
Thank you. As Brian said, I'm Lieutenant Dave Osland. I work for the Michigan State University Police Department. I am the emergency management coordinator for the university. So in that role, I do a lot of planning, a lot of prep work for things like this. Never in my career did I expect that we would have to live through one. And as we've, worked through the last 8 weeks, a lot of my colleagues that I talk to across the state and across the country, it's the outliers, the thing we never planned for. So it's a learning experience for us as we go through it. I have been in law enforcement for actually April is 24 years now. I had 8 years in the UP, up in a small county in the UP, before I transitioned to Michigan State. So I've been doing emergency management, special event kind of activity for 12 years now. I led our emergency management response at MSU for the past 2 years.
My name is Daniel Vosel. I have PhDs in chemical engineering and quantitative biology from Michigan State University. I'm currently the manager for the MSU Flow Cytometry Core, where we are providing support for central research at MSU. We currently have 2 ongoing projects that are directly related to the SARS-CoV-2 virus. In addition, I have around 8 years of experience with designing and engineering delivery vehicles, including those that are viral and non-viral. So with this, because I have just real expertise in reading a lot of the scientific articles about what we currently know about this virus, how it differs from other viruses, and a lot of the other research that's sort of coming out day by day about how to combat this virus. I think you're muted, Brian.
Yep, I just cut myself. Yep. So thank you for your introductions. Real quick before we get started, I just want to make sure that we're all on the same page with what's going on here. We all have a basic understanding of COVID-19 and coronavirus, what the differences are, and what it is that we're all facing. I think we're all on the same page, right? I've been chatting with at least some of you guys. If not, feel free to raise your hand in here, and I'll try to call on you when there's a break between questions. With that said, I'm just going to start going through the questions, starting with number 1. Actually, let me double check with my panelists. Do you guys have the questions up too, or no?
Yep.
Okay.
Yep.
Cool. All right. So question number 1. Will someone please explain the difference between declaring state of emergency and state of disaster? What powers does the state government or parts of the state government have with one declaration and not the other? I know I'm not the only one that doesn't know this.
All right, so I guess I'll take that one. It's in the world of emergency management, those 2 terms are used kind of interchangeably. They're usually not used in the same event. Really, a declaration of a disaster, you're talking more the tornadoes, the floods. There's damage that can be accounted for. What's unique about this one is Governor Whitmer declared a state of emergency early in March. That was kind of her first step into releasing some resources within the state to help out where needed and really kind of start some things planning. So at that point, the State Emergency Operations Center opened up, was manned 24 hours a day, and staff was starting to work on what we do when the response needed to happen. The state of disaster, or the disaster declaration that she put in place, that was a motion where she requested from the president a declaration of a disaster for the state of Michigan. And when Trump approved that then opens up a bunch of federal resources that can come in and support the state, both the state and local municipalities, in what they're doing. So, if you've been paying attention to the news recently, the Army Corps of Engineers is working in the greater Detroit area, standing up a field hospital, one at the TCF Center. And yesterday, they just announced that the show place in Novi is tagged as the second field hospital. So that Army Corps of Engineers is going to finish at TCF, and they're going to move to Novi and stand up and build out another hospital within that center. So without that national declaration, or without the governor asking for that state disaster declaration, a lot of those resources wouldn't be coming our way. We'd be dealing with this at the local level on our own. So does that help, Ryan?
That's fantastic. Thank you. All right, next question. Number 2, and this could go to either one of you, I think, or feel free to both jump on. If we were to do this over, what should we have done different at the community level to produce better results?
So I'll give you my opinion, and this is my opinion. This is Dave Oslin. This isn't any other kind of authoritative opinion. I think the stay-at-home order, as much as everybody hates it, it was a couple of days too late. And I look at Ohio. The state of Ohio did it a couple of days before us. If we look at historically, and not pandemic or pandemic wise, but even tornado disasters and floods and stuff, when a neighboring area declares that, you really need to follow suit, because it's going to end up in your backyard. So I think we were a little slow in doing that. There's conversations about other things that at a community level, I'm not real sure it would have helped much. I think that's the big one. If we would have started a couple of days earlier, we might be in a better place now.
And again, in my opinion as well, as just me as an individual, I think that we could have gotten more scientific information out to the community, with the idea that knowledge is power. So with a better understanding of what this virus is and how to better combat that, I think that people would have been able to respond accordingly. As an example being, knowing that the virus is inactivated after 24 hours on cardboard is something important. So, you don't have to worry about your mail, or your packages that are being delivered. You can just set them aside, go wash your hands, and then you're free to pick them apart after 24 hours. Just some of that basic information, I think, would have a lot of people realize how serious this virus was, what proper precautions that they could have taken were, as well as just some of the basic math behind it. I've seen a lot of people that are confused when they look at sort of the fatality case rate of the virus and say, well, it's anywhere from 1 to 12%. How can that possibly be? Or just some basic information about, this is the math that's used to calculate it. This is where some of the common sources of error can be. I think makes information much more relatable.
Very good. Very good. Thank you, guys. There was a question in the chat related to our first question. I believe Dave's going to follow up on that right now.
Yeah. So the disaster declaration doesn't give the federal government any more powers. What it allows the state to do is request those resources and those things that they can deploy and send in to help us out. They don't do that without that declaration. We have to make that request, and the first step is that getting that declaration. If you follow a lot of the states that don't have that declaration, they don't have the Army Corps of Engineer and FEMA in state setting up things. They're trying to do it all on their own at this point.
Brian, you're on mute again.
Hey, Brian, you're still muted.
Thank you, Dave. I guess you really are the consummate professional on this. Thank you. So the third question on our list here was someone trying to feel out how they wanted to ask the question, but I just copied it as is. Can someone explain why we're constantly told to stay home, yet encouraged to go outside for walks and stuff? Also, what's the risk from being outside in your yard versus in your car or on your bike? Clearly, social distancing is necessary, but how far does that go? Does that make sense?
Yeah, so I'm hoping Daniel will take the piece on the, what's the difference between being in your car or being on your bike. The constantly being told to stay home and the being cleared to go outside and exercise or even go for groceries and takeout. My impression again, Dave, not anybody else, is I think the governor understood that to ask us to lock ourselves in our house for 3 weeks, that was never going to happen. People are going to be outside. We're social in nature. And it's Michigan. We are just coming out of the winter. Cabin fever is at the edge of everybody. And as the weather changed, if you've been outside and you notice the last couple of days when it's been nice, there've been more people out. I think the other piece of it is the walking outside and exercising piece. To stay healthy, you've got to do those things. You sit inside for 3 weeks and you're gonna one, go crazy, but also you're not going to be able to compete against the virus if you do come in contact with somebody that has it. Your body's going to be in a weakened state. You're going to be one of the severe cases if you haven't been out keeping yourself in shape. And Dan, if you can take care of that distance thing.
Yeah, I was just trying to find a video recap that I had from a Japanese study on the spray of microparticles. Maybe some of you have seen it. When I find the link, I'll share it in the chat. But a lot of this comes from statistics and limiting our interactions to prevent the spread of the virus. When we're in closed doors, when you sneeze, we see this like 6 feet distance. That's really for heavy microparticles from when you sneeze or cough or just simply talking that could spread the virus. Whereas when you're in a closed room, there are still much, much smaller particles that just simply sit there and float within the air that contain some live virus. One person can cough in a room and it'll spread throughout the whole room over the course of hours. What we know about the virus so far is that it really takes about 8 hours for it to lose its viability as an aerosol. So again, if somebody coughs in a room, you can still pick up live virus from simply breathing in that room for up to 8 hours. So when you start to think about what can then cut down your interaction with live virus that's in the air, it's going to be things like being out in the open, lots of good ventilation. So as Dave said, it's important to limit our interactions with other people to spread the virus, but so that we don't go stir crazy, we need to know what actions we can reasonably take that don't just confine us to the house. So things like being outside, being able to walk around when there is a good breeze, will certainly reduce the probability of you getting the virus. And anybody that's familiar with probability statistics, nothing's going to be zero, but it is going to be significantly reduced.
Very good. Thank you. All right. Question number 4. How many consecutive days of supportable data will give the confidence that you need to project the flattening event that is sought after?
So I think question number 4 and number 5 kind of are combined. It's going to vary. And as you look at the state of Michigan, it's going to vary across the state of Michigan. I think if you look at the numbers, 80% of the cases in Michigan are in Southeast Michigan. So it doesn't look the same for the Upper Peninsula. It doesn't look the same for Lansing. So it's hard to say how many consecutive days, and the next question asks, who determines that or who announces that. Early on in this, I saw in the news reports and stuff, I saw I don't want to name the news network because I'm not sure it was them, but 2 reporters doing their morning talk show said, you know what, I'm calling this a pandemic. That's a network saying it's a pandemic. At that point, I think worldwide it may have been a pandemic, but for the U.S. it wasn't. We had minimal cases, so I'm looking for the CDC or a national medical spokesperson, somebody at that level, in the state of Michigan, the governor's office, to come out and say that we've flattened the curve and now things are going to change. I'm sure Dan's got some opinions related to this as well.
Well, when we hear flattening the curve, and based on some of the questions that I saw, it looks like some people may not understand what flattening the curve is or means. So for defining that, the idea is if we have 100 individuals that statistically are going to get the virus, it's much better to have those 100 people get the virus over the course of a month than a week. The reason being that our healthcare system can only hold so many new patients or an increase of new patients. If we get all 100 of those at once, there simply aren't enough hospital beds. While we still don't know the case fatality rate of this virus, we do know that in countries where there have experienced some form of collapse in the healthcare system, where they haven't had enough beds to treat all of the incoming patients, that the base fatality rate of the virus has increased dramatically, up to about 300 to 400%. So that's the idea of flattening the curve, is just trying to make sure that not everybody gets this virus all at the same time. So then I think about it for how would we know when we can actually make that as a quantifiable judgment? Obviously, there's still not enough testing to test every single individual. So we're not going to 100% know that the curve has been flattened. So we're going to go to statistics and random group sampling. What some states are doing is they're randomly picking out a set number of individuals for random testing to see how many of them have tested positive for this virus, whether they have it or whether they're over the virus. But a few other things, we might start to see some numbers that are decreasing, but really the lifetime of this virus can, I think, be up to about 28 days. The contagious period and the asymptomatic contagious period also varying to about 5 days you can be asymptomatically contagious, and then you're really looking at about 2 weeks after that. So that's really where I see a lot of the, stay home quarantine for 14 days, because we might have an accurate reading, but to know that that accurate reading is stable, I would say you have to give it anywhere between 5 to 14 days, just because that's where the fluctuations lie within the infectious numbers.
Thank you guys both for that. Since we kind of combined 4 and 5 there, I'm still going to read 5 because it wasn't completely read out loud. Looking at number 6 too, it also looks like we kind of answered that a bit as well. But if there's more you want to address as I read through 5, I'll break for a moment and let you do that.
So with antibody tests, there's 2 types of antibodies. Think about it as a long-term antibody and a short-term antibody. This is, at least when we're doing antibody tests, there are many different types of tests that you can do for this virus. So for the long-term antibody test is more, you've had this, there are 2 different types of antibodies, but the long-term one is indicative of you've kind of had this, you're over it. The short-term one is something that you're actively fighting. So they're really looking at the long-term antibody tests, to know that this is somebody that's had it and they're sort of over the hump, or they have both. This is somebody that's still sort of actively fighting it, but possibly over the hump, or this is somebody that is just sort of experienced the infection.
Right. So again, just for the recording, for the record, I'm going to read 5 and 6 as well. So question 5 was, how exactly will we know when the curve has been flattened? Who will announce this? Of course, Dave said, we'd look to our medical professionals that are at a higher level, or the governor, or the president. Not sure there are answers here, but questions are always good. And other than waiting for a vaccine, will there be a test for those who may have already, will there be a test for those who may already have antibodies without becoming ill, which Dan also just kind of addressed. I don't know if either of you two want to say anything more about that. No? Okay. Number 6 was, can we actually flatten the curve enough to greatly minimize deaths, especially considering how the government has handled it so far and how we are in desperate need of necessary protective equipment? And what does that realistically look like in terms of how long we will be recommended to stay home / stay away from others?
So, the one piece for me in emergency management, when we're looking at it, talking about flattening the curve, the important thing is to look at the number of hospitalizations, and as Dan talked about, that spreading of the ill patients that need to be hospitalized across a greater time frame, so they're not all at the hospital at the same time. And what you're seeing right now in Southeast Michigan is some of the bigger hospital systems are at capacity. So now they're starting to have to stand up these field hospitals, and patients, whether they're COVID patients or regular patients that need observation overnight, are going to end up in those sites. The realistic long-term effect is if we can flatten the curve, there's nobody in those field hospitals. The hospitals are able to maintain the number of beds in a room, and a hospital saying they're able to maintain all of their patients. It may be patients in rooms and hallways and surgical wards and places that normally don't house patients. Then we still haven't flattened it. When we flatten it, it's 2 patients to a room or 1 patient to a room, whatever that standard occupancy is. I think that's kind of back where we get to that. Okay, the hospitals can manage on their own. And I'll let Dan add a piece if he wants to.
So can we actually flatten the curve enough to greatly minimize deaths? I'm not sure what the greatly means as a quantifiable amount, but until this is over, I think we will always be able to flatten the curve more from our individual actions. The reason for that being that this virus and disease is asymptomatically contagious. That's a loaded word, but it is the reason that this virus is different than most others that we've experienced in our lifetimes. So asymptomatically contagious means that you can spread the virus without feeling sick. This is different than any normal diseases that we would get, where as soon as I start feeling ill in the morning, I call my boss and say, hey, I'm not feeling good, I'm not going to come in. And this is an appropriate response because the point where you're contagious is the point where you're not really feeling good. So no harm, no foul. As soon as you don't feel good, you stay away from people. That is not this virus. You can spread this virus for, on average, 5 days before you feel any symptoms. So if you just count that, I only talk to 3 different people a day, and you start to look at, an exponential curve and trend, if you only see 3 different people a day that you possibly contaminate, by the 5th day when you're actually going to be feeling sick, you're up to about 18 different people that are now contaminated and infected, if not more. So that's the real issue with this virus, not that its case fatality rate is horrendous, but that it is so infectious. So just that small decision for you to stay at home and to not potentially spread it, or anybody else in your household to go out and potentially spread it, will have a lasting impact because one individual can spread this so fast. If we look at the case of South Korea, their first 30 patients, they almost had everything under quarantine until the 31st patient came along, who decided to ignore his quarantine after being diagnosed with the SARS-CoV-2 virus. And instead, I believe they went out to 2 different social gatherings that night. They've been able to track, I believe, 80% of their subsequent infections down to that single individual. So yes, you can always have an effect on flattening the curve. It may seem small by staying at home, but the contrast of you being one individual that's out spreading this can be much, much more devastating. And I believe that also goes over to necessary protective equipment. That's, again, why we've been having these stay-at-home orders and quarantine. Just speaking from a pandemic response, statistically, it's one of the best things that we can do to limit the spread of this virus and this infection. How long will we be at home? I think that's going to be a combination of what's going to be safest, what the stats that we see coming in on infections are, before we really know. But from, again, a personal perspective, I think it's still going to be a few months. What me and my family are preparing for is at least till August.
Yeah, I did read about that 31st patient in South Korea, and I will just add anecdotally that they are reported to have infected 1,000 people, which is pretty crazy to think about. All right, number 7. This is for you, Dave. I think the translation of gaps identified in tabletop exercises to potential impacts, approaches they use to quantify and make these best understood to outside audiences. We struggle with this in tech. I'm curious about how it has evolved in the physical emergency realm, and if there are things we can bring into our tech realm of business continuity management planning.
So, you know, at the university, we do tabletops every year. We do full scale exercises. I mean, we run the gambit over a 5-year cycle. Um, Interestingly enough, we talked a pandemic about a year ago. Um, in that case, we had talked about a 30% reduction in our workforce. And how would we manage that? You know, took steps on what the university would do in a limited short time frame, not weeks or months, and what that impact was. We never discussed a 20% reduction in the workforce and 100% of our classes being online. And online for really 5 months. We've said everything through now to the end of August is going to be online. We won't have any face-to-face classes. So I don't think we were necessarily prepared for that. I know that when that decision was made to do that, there was a lot of ingenuity on the tech side. You know, how do we teach professors to use Zoom, to use other online video conferencing platforms? Does faculty and staff have the right equipment? I know that we've loaned out at least 200 laptops. I don't even know what the number of hotspots are that were turned on. I'm going to guess close to 200, where faculty and staff didn't have appropriate Wi-Fi connections at home. So that just, in my time, it was never part of the conversation of how we have a workforce work remotely. I think as we get out of this and we start talking the best practices and how we move forward, that becomes part of that conversation of us moving forward, is making sure that our staff has the technology and the capability to function remotely. I mean, that's the whole kind of concept behind business continuity, is being able to maintain things moving forward, but practicing that along the way as well. It will change everybody's environment after this. There's no doubt in my mind.
Very good, thank you. Question number 8. Actually, I guess it's kind of more of a statement, but I think we can still address it. I'm curious about the mitigations necessary to limit the chances of respread after reopening society. Things like an effective vaccine or a marker that tell us if we've had it already.
Maybe I'd make a few comments. Again, looking at past pandemics and the Spanish flu, all it takes is one country to sort of reopen up their borders too quickly, and then you get these second or third pandemic waves that occur, which I'm sure that Dave can speak more to. In terms of the effective vaccine, I've seen a lot of things on media that say like, oh, one's coming out next week or next month, or even treatments. Just that's not really how these things work. They need to go through a series of rigorous testing. I think the earliest realistic expectations that I've seen or read about would be end of the year, and that's already jumping through a number of hurdles and a lot of fast tracking. So it's not realistic to have anything that's going to come out in the next month or so.
Okay. Question number 9, I guess.
Brian, if
Go
I
ahead.
can, the one thing that I wanted to mention that, and I don't know if Dan wants to speak on it more or not, is, you know, early on in this, we saw people like Dr. Anthony Fauci making statements of, we've not seen the life cycle of this virus yet. So it's hard to say, you know, I know that a couple of the other coronaviruses in history, they kind of died off as we got into the good weather. That may happen with this one, it may not. And that's the part that is the unknown. And as we try and lay out what happens over the next 2 months, 6 months, 8 months, we just don't know that piece of it. And that changes what we do from one extreme to the next. And maybe Dan's got some more points to that.
Yeah, everything that I have seen and read says that it's not going to die off in the summer months. The past viruses that have, and even the controlled environmental studies that have been done with this virus, suggest that those things like the warmer temperature will shorten the spread of the disease. However, the reality is that the environmental conditions for which that virus was run at don't really accurately reflect, right, the U.S. We're not all living outside 24/7. A lot of us are inside and air conditioned. So the translation of those results and their interpretation by infectious disease experts has been that the summer months will have no effect on the spread of the virus, or at least reducing it.
So number 9, I think it was actually a continuation of their thought. I accidentally separated it, but this person says, also, I'm curious about the mechanisms to curb the long-term spread in less sparsely populated areas where infections are much lower and therefore less immunity after. And Daniel, that might be a little more for you. If you don't have any thoughts on it,
I'm not sure about any like specific efforts that are going to be made to spread in less populated or sparsely populated areas, but in terms of the therefore less immunity after, again, that's just more statistics. An area being more or less populated doesn't necessarily change the virality or how strong this virus is. You know, if the statistics are saying that 80% of people that get this will not require hospitalization, will have very mild symptoms, and 20% will require hospitalization, that's roughly going to be true in highly populated and less populated areas. It's just more likely that the models that I've seen for the spread of infectious disease, that obviously hits the major areas first and then trickles out. So my understanding from those projections is once these larger areas have been hit and we start to see that hospitals are opening up, maybe a lot more of these rural areas, when they do get hit, there's just simply going to be more space available for them in major cities, or there will be more doctors and medications and supplies that are free to treat them.
Very good, thanks. Question number 10. I want to know if they understand why there's a reconsideration of the whole mask thing. From everything I've read, the science hasn't changed. So what is there to reconsider?
I can answer from the science. No, the science hasn't changed. One of the things that are areas of research that has really come about from this has been work into the spread of these microparticles from the video that I sent. So it's true that an N95 mask in higher end certification is what's necessary to prevent you from inhaling these viruses. We don't fully know what the effect is, though, of a surgical mask or just simply wearing a scarf. What I've read is suspected is that if when you're talking, there's that 6-foot distance for where you would spread the virus, that wearing any of these other types of masks might cut down on that distance. So it's a small measure that could help to prevent the spread of this virus. Not necessarily that it's going to make you immune when you're out and about, but again, because this virus is so infectious, it's small measures are important and can have larger consequences.
So yeah, I agree with Dan. The piece that I've seen is that the science hasn't changed. What the philosophy behind wearing the masks has, and I think the piece that it comes down to is you as an individual, if you're healthy and you wear a bandana, it's not meant to protect you, but if you're in that asymptomatic stage and you're spreading the virus, what it does is it cuts down on that spread. And one of the executive orders that Governor Whitmer signed over the weekend, there's a section in there that talks about if you have tested positive, you should stay at home. If you have to go out to go to the doctor or have to go to get food or something, you have to wear a mask. And it can be a homemade cloth mask, a bandana. It should not be one of the protective N95 masks that first responders and health professionals have to wear. So that order in and of itself kind of addresses we're trying to reduce the spread of it if you're wearing just one of these surgical masks or a homemade mask. that's the language piece that really, when that came out this weekend, I went, yeah, okay, I can see masks for the general public. And if you look at the psychology and some of the things that have been going on, especially in communities where there was a high international population, when this started, there was a lot of bad feelings towards anybody international, and especially anybody wearing a mask. So now we've got an executive order that says if you have the virus, you have to wear a mask. Well, now when they're out in public, who's got the virus? We know who that person is. So by something coming out to say, hey, everybody just put a mask on if you're out in the public, that kind of takes that feeling and that target off the back of anybody that is sick, if that makes sense.
I just want to add that that was really well put by Dave. One of the things that I'm always very aware of when reading these results and reports is this is very clear and cut and dry that this is simply the right thing to do. But that is not how most people operate. So the real trick for anything in management is, how do I take what I know to be right and how do I get people to do that, or what measures do I take for the general populace kind of given that information, and I don't envy anyone that has to make those decisions.
That makes a lot of sense. Those are great answers. Thank you. Question number 11. If a loved one has been tested for COVID-19 and the results come back negative, why do they still need to be isolated from me for another 3 to 5 days?
Frankly, I just might enjoy a break from you. No. Again, this goes back. My understanding of this question and answer is that it goes back to this asymptomatic infectious period and how these tests are conducted. There obviously is a false negative, a false positive to negative test rates. So they could have been tested, and then they could get a lot worse to where they actually have the levels of antibodies or viral RNA that could be detected. But also they could go get tested. It says that they're negative, but then they could become symptomatic over those 3 to 5 days. Even while they're out and getting tested, they could have been exposed. So again, giving yourself those 3 to 5 days to possibly develop symptoms.
So the other piece of that is that when you look at most of the recommendations are out there, how long you should isolate, what you should do, they're based on symptoms, not necessarily test results. So you've got a severe cough and you're not feeling well today. You go in, your doctor says, yeah, we're going to get you tested. You do the test. Miraculously, it comes back tomorrow and it's negative. That's only been 2 days. But you should, in the next 3 to 5 days, you should still stay isolated, because those things could change, as Dan said. But also, if you look at, and I'll use Ingham County, we have an order from our public health official that says you have to be symptom-free for 3 days before you can consider going back to work, and a minimum of 7 days total from the first onset of symptoms to when you can go back. So there's already some guidelines and requirements that say it's a minimum of 3 to 7 days before you're going back to work. So, and again, that's all based on symptoms, not necessarily a test.
That's really good. I actually, I need to make sure I need to tell someone that about the health official there. All right, question number 12. How about reinfection rates? If one has recovered, how long does immunity last, if at all? Since there's not a lot of research about the novel coronavirus, is there any historical data on on other SARS variants?
Guess I'll take this one. There's not a lot of information about reinfection rates, although what should stand, since we know that you can develop long-term antibodies for this virus, is that you should be covered long-term. Not sure what long-term is defined as for this virus, and probably won't know that for a time. A lot of research about the other novel coronaviruses or any other historical data on other SARS variants. This there are only 2 SARS variants for those who aren't sort of familiar with this. So this virus is a SARS-CoV-2 virus. Sorry, the dogs want to go outside. COVID-19 is the name of the disease. So the virus itself, there are 2 other variants. The other SARS virus that hit.
You just accidentally muted yourself.
All right, I'm back. Where did I leave off at?
You said COVID is the disease. That's the last I remember you saying.
Yeah. Let me pull that up. So yeah, SARS is the severe acute respiratory syndrome coronavirus number 2. That's the virus which is a part of the SARS subset of coronaviruses. COVID-19 being the coronavirus disease 2019, not that there were 18 other ones. But of coronaviruses, there are 39, 7 of which are known to affect humans. 4 of those that are part of the common cold, 3 that are severe, being MERS, SARS, CoV-1, and SARS-CoV-2. A lot of the information that we have about SARS-CoV-2 has come from comparing it to the SARS-CoV-1 virus. And so there are a few things we've identified as being major differences, being the S protein, which is the spike, if you've seen any pictures of the virus. From that information, we know that it's a lot more infectious, but I haven't seen anything that would suggest that there's anything very different about that S protein that would mean that you can get reinfected easily. It should still hold true to other coronaviruses that we can get long-term immunity.
All right, so
If that answers it.
oh, sorry, go ahead. If there's more. Okay. So the next question, it's kind of complex. They're trying to quote a news story. The key quote from the news story is basically, we might not be sticking the tests up far enough people's noses. And also, we don't know how long the active infection lasts. I guess that's the context. The question would be, is there anything we should do to ensure that an effective sample is taken? There appears to be a high rate of false negatives.
So this is with one type of test. There are a number of different types of tests that are being developed for the coronavirus, whether they're based on antibodies, viral RNA, antibodies that you might have within your own blood. So I would say that at least the scientific and research community is aware of this and is trying to come up with new methods that are more accurate and less susceptible to variations in the way that they're collected. But I think that as anything goes, just following the advice of your healthcare professionals and doing what they tell you to during the time of the collection is probably the best that you can do.
All right, question 14. This one came in today. It started off kind of a theory question. China was on lockdown. Supposedly they've had slim to very little new cases, which is good if the reporting's accurate. They lift the lockdown. Are we suspect of them getting a second wave?
You first, Dave.
It's only as good as the data that's coming out. It looks like from what's been reported, yeah, their numbers have not increased dramatically over the last couple of weeks. That would kind of be okay, now it's time to open up. I think it comes down to the science and the virus, but it's also going to come down to their reporting. We won't know if they have a second wave. They could have 5,000 new cases that they have moved out of the public eye, and we just won't know that unless the media reports it.
Yeah, I think it's hard to answer this question without getting to opinions.
That's fine. You don't.
Yeah, I'm trying to think of again, and my opinion on this when I've looked at their data, both the rates of their infections and recovery, I would say that if you were curve fitting other countries' data to theirs, that it appears to be a statistical anomaly. So I very much hope that everything is contained and wish the best to all of those that are currently in China. But I think that from an international sense, and as David said, we've learned a lot from this, infection and disease that we never suspected before. I think that it's wise for everybody to count on, or at least prepare for a second wave globally, whether that comes from any one specific country or not. It's kind of prepare for the worst and hope for the best.
Right. Good. Thank you. All right. Last question. I think this one's more for Dave than anyone else. Where is Dick Cheney's bunker and what's the password to get in?
So I'll take the recording and I'll be searching everybody out if I give you that location, because I just can't tell you that. I read that question and went, what? So I appreciate that.
Yeah. Someone made it as a joke, and I thought, let's end on a bit of a lighthearted note there. All right. So we've concluded our questions that we fielded ahead of time. If anybody has any other questions that they'd like to ask, we've got about 10 minutes left, assuming you guys are okay with that. Okay. Daniel,
People are writing or asking them. I did have one or two notes that I wanted to make. So with the new mandate, right, that we all need to wear masks. I've seen a number of kind of do-it-yourself videos on how to make masks from HEPA filters that you can get at Lowe's and Home Depot. And just a word of advice, a lot of these contain fiberglass. And so as soon as you cut that up, you're now putting yourself at risk for breathing in fiberglass. So if you see any of those do-it-yourself videos or any kind of other homeopathic remedies or things online, try your best to have them verified by a medical or health professional before just following something that you saw online.
And I'll reiterate what Dan said. If the science hasn't changed and we're just really doing it for reducing the chance of the spread of the virus, the HEPA filters and those things aren't needed. It's just, get a cloth mask that if you do feel and you are coughing, this happened to hit the Midwest in the worst time of the season as we're venturing into the spring and you've got allergies and other things that are kicking up. People are going to be coughing. They get the weirdest look out in the public because everybody thinks they've got coronavirus. It may just be allergies, but if they have a mask on and it's just a t-shirt that's been folded up and tied to stop that spread of any particulate, that's the best that you're looking for. I think when you do those other things like cutting up a filter that may have fiberglass in it, or taking a medicine that isn't the right medicine, it just puts too many risks in that factor.
That's solid advice. I didn't even think of the fiberglass aspect of it. I mean, I've not made a mask myself, but yeah, that's definitely something to think about. All right, let's see. Apparently, Joanne Fabrics are giving away kits for making masks, just so people are aware. Thank you for sharing that, Steve. Since we still have a few minutes, if anybody has any other questions, feel free to unmute yourself. I believe you can. If you can't, just shoot me a message in chat here real quick. But you should be able to unmute yourself and go ahead and ask away.
I have one.
Hey, Steve, we can barely hear you.
Uh-oh. How about now?
That's a little better.
Just real quick, I'm kind of wondering about when the cutoff would be. There's a lot of talk about a resurgence of this, and I know you guys have covered that some. I have kind of a high-class problem. We go to Arizona for the winter, and we're going to have to leave Michigan, or hopefully we're going to leave Michigan in the early winter. And I'm wondering if by that time, whether we'll have whether it's likely that we'll have a better idea of whether this is coming back around again. I really do have a lot of fear about getting trapped in Arizona, much as I like it there. Thanks.
What do you think, Dave?
So, from the response side and the planning side of it, it's way too early in the game to even kind of make any kind of guess on what the fall is going to look like. The university's talking multiple different plans based on if or when we kind of go back to some level of normalcy. The domestic travel piece adds another whole twist to it. And, it may not come down to what Michigan and what Arizona look like in the fall. It may be the distance between here and there. If there's a couple of states or 3 or 4 states that are still dealing with this on a high number level, traveling across the country may not be the right choice, even if you are driving in your own car. Flying domestically anytime in the next between now and the end of the year, it's anybody's guess on whether we'll be flying in any numbers or not.
And I would just add that we still don't know whether we've hit the peak of this. The data that I've seen again suggests that I think we're anywhere between 4 or 5 weeks away from hitting the peak. So I guess I'm a little surprised that people are thinking about the second wave, where I feel like we really haven't even felt the full effects of this first wave or really even know when that's going to end.
All right, anybody else?
Yeah. So I've heard some conflicting stories about, I can't remember if it's ibuprofen or aspirin, acetaminophen that may or may not intensify COVID-19 symptoms. Can anyone speak on that, substantiate it, or is that still being studied?
I've been trying to look through my notes right now. I know, yeah, so it looks, my understanding, it's that the receptor that is used for the SARS-CoV-2 virus is the ACE2 receptor. There are a number of medications which can boost or increase the expression of these receptors in cells. So there's been concerns for some like heart and high blood pressure medication that's known to do that. What I've seen from the CDC for those types of medications is that people should continue to take those or consult with your doctor if you have concerns about being positive for COVID-19 and being on these drugs. And I believe that it was, I want to say it was Tylenol, but I'm not sure what it is. I'll try to look that up and find that exact study. And when I do find it, I'll make sure to send that to Brian, who can then send it out to you all.
Yeah, Emily, I don't know. I usually have a couple of healthcare professionals standing next to me to answer these kinds of questions.
Thanks, you guys.
All
Just
right.
make sure you're not taking hydroxychloroquine.
Daniel, since you brought that up, do you want to speak on that a little bit at all? Or
Yeah, I've had a number of people with questions on hydroxychloroquine. So there's been 2 tests that have positively shown that there, was an effect from hydroxychloroquine. But there are a number of alarming concerns with both of those tests, where if you look at all of the medical experts in the field have said it's way too early to make any calls on this. Besides very small patient numbers in those studies, there are concerns that the primary author has been banned from several other publications from falsifying data, as well as that there were a number of patients in those initial studies that had to go to ICU and were in critical condition, which were not included in the results from those studies. So with anything that's any kind of new study, you don't want to jump on it. It's never a good thing until it's been properly vetted. So I would say that for the lay people and everybody else out there, until your healthcare provider is recommending that you take hydroxychloroquine, you shouldn't worry about it. Be confident that major researchers around the world are aware of these initial studies, are looking into it further. But the last thing that you want to do is to jump on any kind of medication too early. And that's, again, some of the concerns with hydroxychloroquine is that if not prescribed properly, it can be lethal. The other thing is, when we say hydroxychloroquine, that has a different meaning to me than you. You might just pick up on the word chloroquine, Google chloroquine, see where you can get it, because this is a one-time cure. There are different types of chloroquine out there, and its availability in different over-the-counter materials. So, for example, chloroquine phosphate is found in fish food, and there have already been individuals that have overdosed because they tried to take this thinking that it was hydroxychloroquine. There's just so many issues with trying to take something that's, claimed as a medical cure. Even if you got your hands on some hydroxychloroquine, how much do you take? What's the right dosage information? All of these are questions that only a healthcare provider that's intimate with, your specifics could answer for you.
Very good. Thank you for that. All right. Well, we're at time, everybody. So I would like to thank both Daniel and Dave very much for joining up with us and speaking with us today. If you guys have any questions, feel free to reach out to me. It's likely that you found my posts somewhere, either on Slack or Twitter or somewhere. I'm happy to disseminate any further materials. Oop, a chat just came in. Let's see. Oh, it was another thank you. So yeah, with that said, everybody please be safe and healthy, and hopefully we'll see you around next month. Thank you.
Thanks.
Thanks, Brian.